Is June 16th, 2020. And we are broadcasting, live streaming spine surgery today from the Surgery Center of Viera and Deuk Spine Institute, thanks to support from the Deuk Spine Foundation. How does that sound, Sean? Does it sound good?
Sounds good.
All right. So we've already performed a posterior cervical laminectomy for amyotomy C3, 4, 5, 6, 7. Instrument infusion from C3 to T2 with lateral mass screws, rods, and pedicle screws at T1 and T2. We did a live stream on that surgery from beginning to end, and that patient's already gone home. He was crying in the recovery room, thanking me for getting rid of his pain that he's had for years. He was a work comp patient who's had 2 surgeries already through the front of his neck. We ended up having to do the surgery in the back of the neck to correct problems above and below his old fusions and to deal with a fusion that didn't fuse. The second surgery we did was a single level ACDF C4-5 with one of the biggest herniations I've ever seen in my career, and that herniated disc was pushing on the spinal cord and nerves, and it caused a lot of inflammation and scar tissue. We got about 90% of it out, and that patient's in recovery. He's about to go home. He's doing great. He has no pain. He has a sore throat, but he has no hoarseness either. So he's doing really good. And our final patient, our piece de resistance, right? Where do you come from? West Virginia. All right, you're not our first patient from West Virginia, by the way. We had one a few weeks ago. Okay, this is Dr. Deukmedjian, and we're going to get started, okay? I know Dr. Patel's already had his way with your back. It's my turn now. So I'm going to give you some numbing medicine. You're going to feel me touching your back. I need to find the right place to inject the medicine. Is that sore? Yes. All right. That's Dr. Patel. He did that, so don't get angry with me, okay? All right, I'm going to give you some numbing medicine. You'll feel a little stick and a burn. That's normal. Don't get upset, okay? Now, we need to have an agreement here. If you have pain, I want you to say, ouch. What I don't want you doing is jumping off the table or trying to move around, okay? So if you have pain, say, ouch, and I'll do my best to make it better. But just don't move. All right, good. Now, I was just telling our viewers who are going to be watching live, we injected 7 mils, that you've been suffering with back pain and left-sided leg pain now for how long? Blood pressure? 1 year and 4 months. Okay. Now, before a year and 4 months, did you have any back pain at all? Yes. You did. So it's actually been longer than that.
Well, the herniated disc is here 4 months, but I've always had a scissor loosen up to help me breathe more.
Well, so you've had back pain for longer than a year.
Yes.
All right, so it looks like we have a pseudodisc at S1, S2 that's very small. All right, so I can see 5-1, 4-5. You've done a nice job with the x-ray. I think I feel comfortable with the levels based on the x-ray. We'll go ahead and get started. So how many years have you had pain then total if it's been more than a year and 4 months? Just keep your head down when you're talking to me. 40 years? 40 years. Oh, 4 years. So if we rewind the clock and go back, if we go back 5 years, you didn't have any problems with your back. Is that correct? Shot? Lateral? All right. So before 4 years, you were perfectly normal with respect to your lower back and your leg. Yeah. All right. So you've been living with this pain for 4 years. And it's gotten really bad in the last year and 4 months. Is that accurate?
Yes, sir.
All right. I'm going to talk to my team for a moment. Let's go ahead and see if we can line up 5-1 a little bit better. I think we need to do a little of this. Maybe your side down. Yep. Let's see what that does. That's better. That's actually really good right there. Let's just lock it in. All right. I understand. I just need you to lay still for me, Shot. I need our anesthesiologist to keep you nice and comfortable while I finish up this part, and then once we get this done, we can put you to sleep. Shot. That's what it comes down to. Once you're asleep, we're able to do the surgery. Okay? Are you feeling any pain? No? All right, we're lined up perfectly with 5-1. But I'm not able to get past the facet joint for some reason. Oh, there it is. All right, you saw that, huh? Shot? Now I'm in the foramen, right where the herniation is. This is the most delicate part. Shot? What? You need your left leg back. Is that what you said? That's my goal, is to give you that left leg back. Are you feeling any pain right now? Give me an AP. So if you look at the needle, it's perfect placement in the L3-S1, and it's right at the back of the disc. Now I got to verify that on an AP view because you can be fooled sometimes on the lateral view alone. Yep, it's perfect. We're right at basically the midline of the pedicle. So go ahead and go back to a lateral view. Just about the middle of the pedicle. We're a little rotated because she does have a little bit of scoliosis. And I want to make sure. You may have to change our trajectory a little bit. Shot. Shot. Are you having any pain? Shot. Let's see where they are. Yeah, I think I want to start a little more lateral. It's almost perfect, but I want to go a little bit more lateral to get a little more medial, if that makes any sense. Shot. Are you comfortable? Yes, sir. Now, you were in the military. You were in the Marines, right? Yes, sir. Are you still in the Marines? No, I got out after the Gulf War. Which one? Shot? Right, there's been more than one. I was in Kuwait. You're in Kuwait. Shot? I'm not going to ask you any details because it wouldn't be fair, being as that you're in an operating room. But you served your country. You love your country. And because of that, I have a lot of respect for you. I didn't tell you my dad was in the Army, did I? I'm sorry to hear that. I know. That's why I didn't tell you. Because telling a Marine when my dad was in the Army wasn't going to get me anywhere. That's right. Now, he served during Vietnam. Yes. All right. Everything's going well. We're just gaining access to those 3 bad discs, and I appreciate your patience with me. Shot? I hope so. I hope I serve you well here today. If everything goes well and God willing, we'll have a good result. Shot? All right, let's get an AP view. So when I do these surgeries, we start out by placing needles, and the needles are going to be used to guide the rest of the surgery. Once again, I like the positioning. You can see the pedicle below the needle, the pedicle above. We're right in the mid-pedicular line. That's right where the back of the disc is. So everything is telling me it's a go. Go ahead and go back to a lateral. I'm going to do this disc, and then I'm going to make an incision, and then I'm going to access L4-5 and then L3-4. We're going to test each disc. I don't need that. Just give me a better shot. There we go. Are you comfortable? All right. Shot, that's 5-1. And we're in really good position for 5-1. Incision. We're going to take our, now we're going to, I need you to get me at 4-5. I think you need to wag a little bit to get, see the pedicle of 4, how they're offset by about 2 centimeters. I need to get that wagged, I would say my side north. Now the reason for this is 2 things, parallax and scoliosis. And she has both parallax and scoliosis. Parallax is the way the X-ray radiation passes through the spine is still not good enough. I need you to improve 4-5. You see the problem at 4-5? Yeah, so the pedicles are offset. That's better, much better. That's actually really good, but we could do slightly better, about 1 or 2 degrees better, maybe 1.5 degrees of wag better. It's almost perfect. That is perfect. Yep, so let's keep that there. Are you comfortable? Yeah. Everything is going as planned. Just to keep you in the loop, okay? So I'm very happy with the way things are going. You let me know if you're uncomfortable, okay? All right. Shot. Let's go with an AP. Yep. Blood pressure is good. Can bring it down just a little bit. Don't take the AP yet. Wait. Let me know when you're ready for an AP. Shot. Looks good. Back to a lateral. So the AP and lateral are pictures we take during surgery. I'm actually using a special machine called a fluoroscope. And a fluoroscope takes X-ray images while we're doing surgery. Shot. And those images are used for me to use those images to basically guide the placement of the needle, which guides my access trajectory and entry point. Very important. Shot. All right, so I'm coming around the facet joint at 4-5. Shot. Very close. There it is. Perfect. Where's our pressure? Is that it? That's perfect. I'm in the foramen. You feeling anything?
Yes, a little bit.
Where?
Right where you are.
That's you. Shot. I need a shot. All right. Where do you feel that?
Right in the center, right to my back.
All right. You're doing great. We're almost done. Would it be okay to say you're a real trooper?
Yes, sir.
Very good. I like that. All right. We're going to have you asleep in about 5 minutes, okay? When you wake up, we'll be done. Shot. So I need to focus on 3-4 at this point. And it doesn't look too bad. We're pretty close to being where we need to be. I would like to optimize it if possible. Shot. That looks pretty good. 3-4 is pretty collapsed, as you can tell. We're going to really need to aim north. Shot. 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 Are you pulsing?
Yes.
Shot. Let's see if I can do a better job. Shot. Trajectory is decent. Shot. 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 Perfect. All right. Very happy with that. Are you comfortable now? Who did you come here with?
My sister.
All right. You comfortable? How bad is that on a scale of 1 to 10?
10.
Is that your typical pain?
Yes.
That was L3-4, the top disc we talked about yesterday.
Oh,
It's painful, and it causes your typical pain, right?
I guess.
Well, no, I mean, you felt pain in your back, and you felt it where you normally feel it.
Right.
Yeah, so we're going to fix L3-4. I would turn it this way, so that doesn't happen. So I'm glad we included that one, otherwise you'd still have that pain when we were done. Yes, you are blessed. You better now? How bad is that on a scale of 1 to 10? 20. All right, so that's L4-5. 3-4 was a 10. 4-5 is a 20. Is that where you typically get your back pain? You're so cute. But that you feel it in that area, right? Yeah. It's a concordant. The good news is we're about to put you to sleep. Okay? That's L5-S1. How bad was that? How bad? 20. You didn't say higher than 20, did you? You're not allowed to say higher than 20. How bad?
That's worse.
Give me a number. 20. All right. We're done testing them. They all need to be fixed. It's a good thing we did this. When you wake up, we'll be done with surgery and you'll be a new woman. And you can go back to kicking those guys' asses in the military. All right? All right, count from 1 to 100 for us out loud. Shot. All right, we need to drop the table. So, folks, if you're watching, I know there's some people out there watching this, but we just tested 3 discs with a discogram, and all 3 discs were causing her typical pain. The L5-S1 was probably the worst. Shot. She okay? Can we move forward? I'm going to start with L5-S1. Shot. She's doing good? All right. When she wakes up, she's not going to have any of the pain she had in her back before surgery. It'll all be gone. And I expect her leg to be better as well. What are my averages for the Deuk Laser Disc Repair? 95%. Shot. We have 95% elimination of back pain and 95% elimination of leg pain with this surgery. Shot. I've got to be careful and just keep a close eye on the tip of that guide wire. It's right at the front of the disc. I don't want it going any further in. All right, shot. We're in the foramen, right where the nerve root is. You can actually see the nerve root there, outlined with dye. Shot. Perfect. So, for those of you who don't understand what's happening here, we've got access to 3 discs. We've tested all 3. You're doing great. Just lay still. Is she breathing okay?
Yes.
and we're actually getting into the bottom disc, L3-S1 first. That's where that big pencil-like thing is going. Shot. And I'm moving in just underneath the nerve. All right. And we're ready to place this dilator into the actual disc itself. Shot. Shot. All right. Tell me if I can proceed. Huh?
She's breathing.
She's okay?
Yeah.
All right, you want me to go forward? So I need to get the dilator into the disc space. Shot. Of course, any kind of movement makes it difficult to visualize, but that's okay. As long as she's safe, I can work with what I've got. Shot. Try to time it so it's when she stops moving. That's good. Yep, that's good. I'm going to bring the guide wire back just a little bit first. Shot. Shot. Well, at least she's relaxed. So I can get this dilator in easier, which is good. It's really about a 45-degree angulation. That's a guesstimate, of course. It's not exactly 45 degree. Shot. Now we're bringing the tubular retractor over the dilator. Shot. Into the disc space itself. Shot. Now they're both moving forward. So we want to grab this dilator and bring it back a little bit. What is it? Shot. All right, we are in good position with the tubular retractor. I remove the dilator. Shot, and we're ready to get the fluoro up and out. We good? Okay, no problem. We can do that. I'll take this. All right, any questions from our audience? Sean? Remember, audience, you get to ask questions. That's why we live stream. Otherwise, we just post a bunch of videos of surgeries and let you just watch them. But this way, you get to interact. You get to actually participate in the surgery with us, as though you were here, standing next to me, asking me questions.
This one right here helps to
Yeah.
keep the water.
All right, we are ready to rock and roll. Scope on. Okay, we're inside the L3-S1 disc, and automatically, right away, I can see there's a lot of inflammation. That's the red stuff. Inflammatory tissue from the herniation. That's a piece of herniation right there. We're going to take it out. Kind of broke off. Wipe. Any questions, Sean?
None currently.
All right. I got to tell you, our live streams are strange. Sometimes we get a lot of questions. Sometimes we don't get any. Yeah, we had a few thousand, but not 100,000 like we've had in the past. Sometimes we have 100,000 viewers. There's a piece of herniation. She's moving just a little, but I'm okay with it as long as she's... Everything's okay. Everything's going well. All right, let me have the laser.
We have a question.
All right, good. We have a question.
One of our viewers is wondering, in layman's terms, what is the tube used for?
Well, in layman's terms, what is the tube used for? Great question. The tube is our pathway. It's our highway into the disc to fix it. Without the tube, we have no way to get down there and fix the tear inside the disc that led to the herniation. It's the tear in the annulus that's the cause of the back pain and the leg pain, really. That tear is full of inflammation. The body is trying to heal the tear constantly, and therefore it's constantly in the healing mode. And the first step of healing is inflammation. Everybody knows that. When you have an injury to your body, no matter what tissue is injured, whether it's your skin, your bones, your liver, kidney, doesn't matter. Inflammation is the first step or stage of healing. So this tear in the disc, the annular tear, is what this surgery fixes. It's the only surgery in the world that does this. There's no other surgery in the world that fixes the annular tear. And the Deuk Spine Institute is the only place in the world that fixes the annular tear. As a matter of fact, we were the first one. I was the first one to describe this surgery, fixing the annular tear, because I figured out the annular tear is the cause of pain. Nobody else could understand where the pain was coming from. They didn't know. And the annular tear is the source of back pain and leg symptoms too. So as the discoverer of that fact, I then developed a treatment that would address the source of pain, aka the annular tear. Other surgeons don't address the annular tear. Therefore, they can't really get rid of back pain. Now, if you do a fusion, you can get rid of back pain because a fusion clears out the annular tear also. But it also fuses your spine and stops the movement. So it's really too much. You don't need to fuse the spine to stop the pain. This surgery you're watching here allows us to treat the tear that causes the pain without fusing the spine. So there's no loss of movement. For example, this patient came to our clinic to have this surgery from Virginia, West Virginia. And she came to me because she didn't want a fusion. And she was offered a fusion, I believe, by other surgeons where she lives. But she didn't want a fusion. And they were only going to fuse one area. So she would have still had pain. You see, she has 3 bad discs. This is one of the biggest problems we face today in healthcare and spine care of patients is that surgeons will only treat one disc at a time. Well, the patient's going to end up having that treatment and then needing another and another because they have 3 bad discs that are causing pain. So why would you want to make a patient have 3 surgeries? There's really no good reason to do that to someone, in my opinion. There's only one reason I can think of, and that is that you want them to come back 3 times and pay you 3 times. But to me, that's unethical. You want to fix somebody right the first time. Maybe kind of simple, but that's the way I was brought up, is you do your job right the first time and you don't have to repeat it. I think it's a bit old-fashioned now, isn't it? But I think it's a good thing to live by, a good code. Do things right the first time and you don't have to repeat them. My dad taught me that. He was from Alexandria, Egypt. Right? Just same place Sam is from. Have you heard that before? Is that an Arabic thing? I'm trying to figure out if it's Arabic or if it's American or what it is.
I think that that is saying Arabic, if you do something, just do it good.
If you do something, do it to your best. Do your best. Right?
Yes, correct.
That's Arabic. How do you say it in Arabic?
إن عملت شيئا فاصنع عملا.
Oh, I'm going to have to take some time on that one, and that's not as easy as some of the other words I know. All right. We actually have a patient coming from Dubai I think next week or the week after to have laser surgery. So we're going to be able to speak Arabic with them.
Yep. I can definitely help.
I know you. It's exciting having people from all over the world come here to have surgery.
It is.
They don't have surgeons that can do this kind of surgery in Dubai. They don't have this type of surgery in anywhere in the world, as a matter of fact. Except for the United States. There is endoscopic surgery, of course, but the specific surgery we're doing, where we're repairing the annular tear, is only done here at Deuk Spine Institute. Okay, so the tube, just to expand a little bit more, she's moving a bit. If we can give her a little bit better control. The tube, the metal tube you're seeing, is our access to the disc. At the end of the tube, right where you're seeing this little blue fiber, this is the end of the tube inside the patient's disc, and the end of the tube is right in the herniation, literally buried in the herniation. So I'm using the laser energy to break up the herniation into little pieces and remove those small pieces. And the reason why this is such an effective tool, the laser and the tube, is because the herniation doesn't want to come out as one big piece. It's so stuck together from all the inflammation and scar tissue for the years and years that she's been suffering. This right here that I'm working on is the tear inside the disc called the annular tear. That's spelled A-N-N-U-L-A-R, annular tear, and this is the source of her back pain and her leg symptoms. By removing and cleaning up the annular tear and removing the small herniation, I'm able to eliminate her back pain and her leg symptoms.
We have another question.
Sure.
One of our viewers is wondering, is scar tissue synonymous with inflammation?
So one of the viewers is asking, is scar tissue synonymous with inflammation? The answer is no. They are not the same. Inflammation is a process that involves cells. Therefore, it's called a cellular mediated process. But it involves more than just cells. It involves inflammatory mediators as well, such as cytokines, interleukins, basically molecules that cells use to signal to each other. The most important thing is that inflammation is a very complex process that involves many different kinds of cells, including vascular cells, fibroblasts, macrophages, polymorphonucleocytes, histiocytes, and it involves the release of inflammatory chemicals that are released by cells that promote changes locally in the area of inflammation. And those kind of changes include swelling, that's a piece of herniation, by the way, right there in the tube I'm taking out. Don't move. We need to get better pain control, doctor. I can't have her moving around like this. So swelling from edema, which is basically leaking of your capillaries in the area of inflammation. So the capillaries become very leaky, and they allow an exudate of water from the blood system, from the vascular system, to leak out into the tissues. You also have a sensitization of the nerves. You have more blood flow to that area, again mediated through cytokines that promote blood flow by enlarging or engorging the blood vessels. So inflammation is a process that involves many cells over time, and you get changes like redness, swelling, pain. Those are all due to inflammation. Let me know when I can proceed. Now, scar tissue is just collagen and elastin that are produced by a cell called a fibroblast and released outside of the cell in the tissue. And over time, those fibroblasts produce collagen and elastin, and that is white material. It's connective tissue, and it doesn't have any cells in it. It's acellular. And its purpose is to repair tissues in the body. It's the end product of inflammation. So the scar tissue that forms, which is avascular, a bunch of collagen and elastin, is the end product of an injury in which inflammation is the first step and scar tissue is the last step. All right. Can I proceed or what? This is the most painful part of her tear that we're working in. So she's responding. She's going to need the most amount of pain medication right now. All right, you've got to learn the sequence, doctor. The inside of the disc doesn't have much nerve fibers. The outside has a lot. This is the most painful part of her tear. And every single disc that I do is going to be exactly the same way. So it's very predictable. It just takes paying attention and being prepared. If you need me to stop, I'll stop. So think about inflammation as a process that cells perform in a localized, very specific part of the body where there's a foreign body, like a splinter or a bacteria or a fracture, or in this case a tear in the tissue. And that tear has allowed the jelly in the center of the disc, called the nucleus pulposus, it's allowed the nucleus pulposus to come out through the tear. Now that nucleus pulposus is truly considered a foreign body because your body's never seen it before. It's hidden away inside the disc your whole life, except as an embryo where it's the notochord. This is involved in development of the fetus. Just lay still. Everything's all right.
We have another question.
Sure.
Our viewer is wondering, are most of this patient's leg symptoms and pain coming from L3-S1, or is it spread out between the 3 levels?
Great question. So this patient's pain is coming from 3 levels. We tested those 3 levels because I looked at the MRI. The MRI had a bulging disc at each level, L3-4, L4-5, L5-S1. And I thought, okay, all 3 of these discs could be causing her pain, but let's see where her pain is on exam. So I did an examination. For her, I did an examination over Skype, over the internet with a video. And she pointed to L3-4, L4-5, L5-S1 as where her pain comes from. So I knew based on her exam that her pain was coming from an area that corresponded to the L3-4, L4-5, L5-S1 discs. Then on the MRI, I saw there was herniated or bulging discs, the same thing by the way, at 3, 4, 4, 5, 5, 1. So I used the physical exam, I used the MRI, and I used all my experience to know that those 3 discs were the cause of her pain. What I did in surgery today was I confirmed that. I confirmed what I already knew. So when we tested them, all 3 were positive for producing her typical pain that she has every day. So I believe when she's done with the surgery, as she's recovering 30 minutes after surgery, she's going to be able to say, my pain is gone, that I came here with, that I've had for the last 4 years, all gone, completely gone. I expect that from her. That is what we almost always see, 99.999% of the time. Pain is gone, which is an incredible thing for somebody who's been in pain for so long. All right, standby laser, grab her. So I used my many, many years of treating back pain, plus the MRI, plus the patient's physical exam where she showed me her pain was. I used all that information to create a surgical plan to fix these 3 discs, and I knew that fixing them would fix her pain. So let's see if I'm right at the end of surgery. She's going to be back tomorrow to see us in clinic for a checkup, but I think if she's willing to actually share her experience with you, I think she'd be willing to tell you in recovery today that her pain is gone. She's kind of asleep right now, in and out of asleep. The anesthesiologist is doing his best to keep her comfortable because this is a painful part of surgery. If you were awake for this right now, you would feel tremendous pain in your back. As I'm zapping with the laser, I'm zapping away the herniations and cleaning up the tear that's causing her pain.
We have another question.
Sure.
One of our viewers is wondering, if you already have a fusion in the lumbar spine at L4-5 with cages,
Yep.
can this procedure help with lower issues at L5-S1?
Great question. So one of our viewers says, Dr. Deukmedjian, I've had a fusion at L4-5, which, by the way, L4-5 is the most common disc to go bad and cause pain in everybody. The second most common disc is L5-S1, the disc below L4-5. So this person's saying, if I've had a fusion with cages and screws at L4-5, could I have this surgery, the laser surgery that you're doing right now, Dr. Deuk Laser Disc Repair, could I have this done at the next disc below, L5-S1, to fix that disc? And the answer is 100% yes, you can. And that's what I would recommend, rather than going through a second fusion. We've done many, many, many patients that have had fusions already, and we fixed the discs above or below with excellent success. It works. It works beautifully. So you don't need to have anything else, but you can have the laser surgery done to fix your pain. All right. You can see there's a little bit of bleeding right here from an epidural vein. I'm not concerned at all. It may seem like a lot to you guys, but it's very little. Honestly, if you're a diabetic and you poke your finger to get some blood for your test, that's about how much bleeding you're going to get right there. It's literally a few drops of blood. It just looks like a lot because we're under the endoscope. We're under a highly magnified situation where we're seeing all this stuff really blown up big because of the lenses, and we're basically sticking a microscope down inside the spine. So we're able to magnify everything much bigger than it really is. This is the last of the herniation at L5-S1. You can see the bone down there. That's the end plate of L5, and then the end plate of S1 would be on the other side. This is the tear right here, and I am actually debriding the tear. This is the cause of the patient's pain. Every single human being alive on earth has one of these tears, at least one in their back or in their neck. The vast majority of us have inflammation, and that inflammation then seals off the tear with scar tissue, and that scar tissue acts as a barrier. And so we don't have pain because we form an effective scar tissue barrier against inflammation. And this patient, unfortunately, couldn't make that barrier work. And people like her that have a tear with a herniation, they're all in the same boat. They just can't heal the disc tear properly, and they end up having pain every day until I come along and fix it for them. Just lay still. Everything's okay. You're doing great. Just about done. Another 30 seconds to a minute. This is the last of the tear I need to repair right here. And we'll be done, and we can move on to the next disc. Yeah, I think that's a great idea. Thank you. Oh yeah. Trust me, when you wake up and this is all done, you're going to be one happy camper. Just lay still. Oh yeah. See that tear? You're doing great. All right, we're done. Laser.
Lights on, please.
Scope off. Just lay still. You're doing really good. Let me have the dilator. All right, that was L3-S1, herniation. Next, we're going to work on, here, take the scope. We're going to work on L4-5. Now, let's pull this fluoro back a little bit. I want to show our audience what we're doing here. All right, so we had a question like, what's that tube for? Can you all see the tube right here? Sean, can you show them this tube?
Yes, we can.
This is the tube. It goes right through her back into her spine. Sits right inside the tear, the annular tear and herniation. Keep the fluoro back. I'm going inside with a camera and an endoscope. This is made in Germany. It's like $12,000 endoscope. And I'm going in here, down the tube, and we're looking all the way inside her body. That's how you do endoscopic surgery. So that's what the tube is for. It's a pathway or portal for me to get to her herniation and fix her herniation. All right, we're going to get this tube out because we're done with L3-S1. We've got 2 left. That's why we still have 2 needles there. All right, so let's get our scope back in. Our fluoroscope, not our endoscope, our fluoroscope. Let's get our fluoroscope back in. Move away, please. Monica, the queen is here. It doesn't matter. Just go lateral. We're not going to do an AP. We only do laterals at this point. We've already done with the APs. All right. Any more questions? We've been getting a lot of audience questions, which is fantastic. I like questions. That's how I teach. Drop the scope all the way down to the floor.
We do have one. A viewer is wondering, can this procedure be done in the cervical and thoracic spine?
Can this procedure be done in the cervical spine and the thoracic spine? The answer is yes to both, with limitations in the thoracic spine. So in the cervical spine, the most common disc herniation is C5-6. The second most common is C6-7, then C4-5, then C3-4. I need a fluoro shot. That's perfect. Keep it all there. So this procedure works beautifully in the cervical spine at C3-4, C4-5, C5-6, C6-7. It's when you get the really weird herniations like C2-3 or C7-T1, which is extremely rare. Shot. That's when I can't do those. I can't do those herniations. Okay. But I can do shot. I can do the more common ones, if that makes sense. All right. So we've got our guide wire in place, and I'm taking the needle out. Shot. Let's make sure the guide wire is still there. It is. We're going to do the L4-5 next. Now in the thoracic spine, I've done T10-11, T11-12. I want to say T12-L1. I've done one of each. And they're very rare to do in the thoracic spine. Shot. Because the truth is that thoracic disc herniations are rarely symptomatic. First of all, thoracic disc herniations rarely ever happen. Shot. So they're not common. And then when they do happen, they rarely cause symptoms. Are we okay? Okay, remember what I taught you. We're at the annulus. This is going to be painful for her, all right? So this part right here for the next 2 minutes, and then when I'm doing the laser, I'm coming out, and I get to the outer annulus, that's when it's going to be the most painful. All right, so the fact that, just lay still, everything's okay. The fact of the matter is, shot, is that thoracic herniations are rare. And they rarely ever need treatment, but If you have a lower thoracic herniation, T1011, T1112, T12L1, I would be willing to do it with the laser as long as it can be done safely. Lay still. Perfect. So you can see the dilator is there. Now the tubular retractor is next. We're halfway done. You're doing great. So our patient is not intubated, remember. She is covered with drapes. She is laying on her belly, and she is breathing through her own mouth and nose. And our anesthesiologist is just giving her some boluses of propofol or drip of propofol to keep her asleep and comfortable. But she's going in and out of sleep. Okay? And so there are times that she's more asleep, and there are times she's less asleep. That's you. That's you. All right. We're good. Now go ahead up and back. So when she's less asleep, it's okay to be less asleep as long as I'm not causing her pain. But the moment I start working on her tear, she's going to want to come off the table. So the anesthesiologist has a job of juggling between keeping the patient safe and awake or more asleep, deeper asleep. But the deeper asleep a patient is, the more likely they are to stop breathing. And we don't want our patients to stop breathing because that's how people die. We've never had anybody die. I, in 22 years, have never had one of my patients die from anesthesia, or die for that matter. And I don't want to start now. So the anesthesiologist, a good anesthesiologist, juggles between, just asleep enough and just awake enough to be safe, and just asleep enough so they're not in pain. We do need the scope turned on. Louise, help her out.
Stand by, monitor. Stand by. There you go.
Nice job, Monica. So now we're looking at L4-5. We're inside the disc. That's the tear at 12 o'clock. We're going to try to pull out any herniations we can just easily grab. And it took me a long time to figure this out, but why would there be herniations inside the disc? And again, the key word is inside the disc. The reason there are herniations inside the disc is because we just shoved them in there. When I put that dilator down over the guide wire, it literally pushes herniated discs from the outside into the inside of the disc, which is a technique that's pretty standard for open surgery and endoscopic surgery, is to move the pathology from where it could be dangerous to the nerves in the foramen, to move it inside the disc to where it's safe to take out. So it's actually a brilliant technique. I did not develop that. Dr. Anthony Young did. He taught it to me. And yeah, anyway, that's one of his contributions to my technique. Dr. Young was probably the most significant mentor I had in endoscopic spine surgery. Dr. Anthony Young. He was the #1 in the entire United States of America for many, many years. And he practiced out of Phoenix, Arizona. His son, Chris Young, is also a spine surgeon, but he's orthopedic like his father. And Chris likes doing instrumented cases. So he followed his dad's footsteps and went into spine surgery as an orthopedic spine surgeon, but he broke away from his father, and he likes doing fusions and cages and artificial discs and things like that. So Chris and I went to UC San Diego. Both of us have graduated from UC San Diego, University of California, San Diego, extremely prestigious university on the West Coast. Both of us pre-med. It's funny because Chris I was taught in the complex spine world by some of the best complex spine surgeons in the world, how to do screws, rods, reconstructions at University of Florida in Gainesville. My teachers included Richard Fessler, who still teaches, and Glenn Rechtine, who was a head of spine surgery in the Army, and then went into private practice, academics basically. Jeffrey Henn, who trained at the Barrow Neurological Institute, trained with Curtis Dickman and Volkner Sontag, two of the most recognized around the world as two of the best spine surgeons for complex spine surgery in the world. I would say Patrick Jacob, but if I say Patrick Jacob, I have to spit because he's such a scumbag of a human being. And honestly, he did teach me a little bit about spine surgery, but he taught me more about how evil human beings can be to each other. Yes, I get to say that, Pat, because this is my show, and you're such a low-life slug. Pat Jacob spent the last few years of his career as a neurosurgeon denying veterans surgeries for their spines, life-saving surgeries, corrective surgeries to heal their spines. And that's what he did. He sat in an office and he just said no, 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 no to every surgeon that requested to fix a vet and get them out of pain. And Pat Jacobs was paid to deny them their surgery. And I always like to bring up my stories about Pat Jacob, which my staff have heard now at least 3 times. How when I worked at the VA hospital in Gainesville, Florida with Dr. Jacob, how on 2 separate occasions patients showed up with guns wanting to hunt down a doctor and kill him. Of course, the police had to take over. Don't do that. You're going to lose that. You need to talk to him, Luis. Of course, unfortunately, they never found Dr. Jacob. Had I known better, I might have led them to him at the time, but of course, I was very, I don't know, 120 hours a week was what we were working, and we were pretty exhausted mentally. And we took a lot of abuse from our attendings every day. But Dr. Jacob gave the worst abuse, and it was completely unwarranted, undeserved. So I don't think there's a single resident who likes Dr. Jacob who graduated from that program. Anyway, Dr. Jacob was one of my instructors as well. He did teach me some good techniques in spine. So I was trained by a lot of very good spine surgeons in my program, fortunately. And the reason I say fortunately is that the University of Florida in Gainesville was literally one of the top neurosurgery training programs in the world when I was there, with Dr. Albert Rote in his chair, Bill Friedman, Art Day, Rick Fessler, Parker Mickle, Jeff Hand. And this program was known and primarily known to do brain surgery, which, of course, as a neurosurgeon, I'm trained to do brain surgery. But we also do spine surgery. And I was fortunate because the chief resident, when I was a senior level resident, which is just under the chief, was Greg Zipfel, who ended up wanting to become, who ended up becoming an aneurysm surgeon, a vascular surgeon. So he wanted to do every single vascular case that was on the books every day of the week. And as the chief resident, that was his right. As the chief resident, you get to pick first which case you want to do. So he always had first choice. I had second or third choice. And I was fortunate that the senior residents to me always wanted to do the aneurysm surgery. So I ended up being able to do all the spine surgery. For about 3 years, I did spine surgery every single day with the top spine surgeons, some of the top spine surgeons in the world, right in our own program. So that's how I developed a real interest in spine surgery. Do not do that. You're going to lose this. Don't do it again. This heavy part of this instrument must be in the center. That's a $1,200 instrument. If it falls on the floor, it will break. And we'll have to get another one because it won't be sterile anymore. Okay? Please be careful. I don't like repeating myself. So once again, I was able to get a very good education in spine surgery for about 3 years. Extremely intense training. And prior to that, I did a lot of surgery on the brain because I did my fellowship at UF with Dr. Roper in epilepsy neurosurgery. So I was operating a couple of times a week doing brain surgery just for treating epilepsy patients to help them get rid of their epilepsy. But I never fell in love with that field. I really fell in love with spine. And so despite 2 years of intensive training in epilepsy surgery, it's not something that I use really in the majority of my career. I'm sure Dr. Roper appreciated my time serving him and helping him in surgery. I did a lot of vagus nerve stimulators, which is a procedure where you treat seizures that are refractory to medication by going in someone's neck and basically wrapping a metal coil around their vagus nerve, which basically runs. This is, again, remember what I told you, we're starting to move to the outside of the disc where the pain fibers are. And I used to wrap a coil with Dr. Roper around the vagus nerve and then connect it to a little battery generator. And what that did was it would send electrical impulses all the time onto the vagus nerve, but it would increase the frequency of those impulses during, basically to prevent seizures. Somehow stimulating the vagus nerve was known to like block a seizure as it starts to develop. The point is that I did a lot of dissections on the neck during those 2 years of fellowship with Dr. Roper. So I got to learn the neck anatomy really well, probably better than any other neurosurgery resident, because I was so used to doing those surgeries on the neck. So it really helped me with my anterior cervical discectomy and fusion surgeries, right? A lot of residents get confused. A lot of spine surgeons get confused about the anatomy of the neck, and they get lost. Then they start cutting things they shouldn't cut, like I told you guys earlier about that surgeon who cut through the esophagus in a patient recently during an ACDF. And the patient had to be admitted to the hospital for 2 weeks and put on a feeding tube and almost died as a result of that injury from the surgeon during a simple surgery like an ACDF. So I was very lucky to have all those vagus nerve simulator cases I did where I got to do the exposures for Dr. Roper, and he actually let me do a lot of the placement of the electrodes on the vagus nerve once he learned to trust me and my technique, because I had very good operative technique. I was one of the better residents when it came to using my hands. It would be surprise you, but some neurosurgeons, they're all brainiacs, but some of them have horrible coordination of their hands. Some of them have shaking, some of them have 2 left hands. We had one resident who had the highest score in the nation on the board exam, and he was known as Lobster Boy because because he couldn't use his digits. He used his hands like lobster claws. I mean, if you watched him operate, he was like this when he was operating. That's all he had was this basic pincher motion. It's like all the neurons in his brain went to memory rather than to the motor cortex or the premotor cortex that controls fine movements of the hands. You know, it was like his entire cranium was filled with neocortex rather than the cerebellum having any lobes or anything. He probably had a very small posterior fossa. Anyway, long story short, he's a good friend of mine. But they used to call him Lobster Boy. I never called him Lobster Boy, but the senior residents called him Lobster Boy. They were very mean. But fact of the matter is, they were making fun of the fact that he had horrible coordination of his hands. And that's just, some neurosurgeons are just mean. They can be mean people. But I'm not going to tell you who this person is. I'm just going to tell you what they call them and why they call them. All right, we're pretty much done here at this disc. I think I'm going to go a little bit lateral right here because this is also a problem. That's just fat getting in the way there. No big deal. patient has a little bit of fat, just outside the foramen. No big deal. I'm not going to do anything with it. But I want to make sure I get this last part of the disc here laterally.
A couple questions.
Yeah, sure.
One of our viewers is wondering, do you have a preference of using titanium or cobalt rods in hardware, or do you have another preference entirely?
Yeah, great question. So I do have a preference with hardware. My preference is titanium. I've been using it for years and it's served me well. Excellent, you know, of course you want to make sure the manufacturer is a good quality manufacturer. But titanium is actually an alloy of metals. It's molybdenum, chromium, and zinc. And different companies manufacture different types of titanium. But the truth is that for many years we used stainless steel and laser off. And the problem with stainless steel is that it's too hard. Actually, keep the scope on. Keep the scope on. The stainless steel is too hard. It's too brittle. It breaks. The nerve is right in there. Can't really see it. Let me just get a little bit more here real quick. So stainless steel was the original screws, rods, hardware. And there were a lot of failures because stainless steel is just, it has no bend, no softness to it. It's just too rigid. And originally we thought, oh yeah, the harder the metal, the better, right? But the reality is that the hard metals actually are bad because they have no flexibility. And as the patients are healing, good off, they're bending a little bit, and those rods can break. So I don't like rigid hard metals for hardware. I like metals that have a little bit of softness to them so that they're firm enough to hold the spine in position, but they have a little bit of play so that they don't break. So titanium is my favorite. As far as cobalt, I don't have a whole lot of experience with cobalt systems. I've used titanium and it's worked well. I don't see a reason to change. I've had great results with the titanium, and I have no plans to change at this time unless someone can give me really good scientific data and show me better results. But I don't know if that answers your question. I hope it does. Come on in. Yeah, lateral. Yep.
We have another question.
Certainly.
One of our viewers is wondering, are patients suffering from degenerative disc disease candidates for this type of surgery?
Yes, so the question is, are patients who suffer from degenerative disc disease candidates for this type of surgery? The answer is 100% yes. Every one of these surgeries I've ever done has been for degenerative disc disease. Remember, degenerative disc disease starts with the most basic form is an annular tear. Shot? So every single patient with degenerative disc disease started with a tear in the annulus fibrosus, aka annular tear. That annular tear then is a path for the jelly in the middle of the disc called the nucleus pulposus to leak out through the tear and get outside the annulus. And that's called a herniation. If it's a small herniation, we call it a bulge. If it's a big herniation, they call it a herniation. But bulging discs are herniations. They're just small herniations. All degenerative disc disease starts with an annular tear, then a herniation, and then the disc collapses, and you get more tears and more disruption and bone spurs. So that is a whole process of degeneration that starts with a herniation. And yes, at any stage of degenerative disc disease, any stage, this surgery works. I've seen this surgery work on people who have no disc left on MRI. They have a tiny little nubbin of annular tear and no herniation. And I go in there and I zap that tear away with that granulation tissue, that inflammatory mass that's stuck on it, and their pain goes away. It's like miraculous. So, to answer your question, yes, degenerative disc disease is a great candidate for this type of surgery. As long as you're having back pain or neck pain that's coming from the disc, I can fix it with the laser. Shot? All right. Spinal stenosis, same thing. Spinal stenosis is treated with this surgery just as well. Lay still. We're almost done. One more disc to go. Shot? All right, the dilator is in the foramen right at the back of the disc. I'm going to advance it now into the L3-4 disc. Am I okay to proceed, doctor? Shot? Yep. That's going in there. Shot? Let's see where we are. I'll put it a little bit more. Perfect. So the dilator gets inside the disc through the tear. Next comes this tube, tubular retractor. You all see this? You want to zoom in on that, Sean, so they can get a good look at this thing? I call it the McDonald's shake straw. That's only because I'm hungry and I like shakes. Chocolate's my favorite if you ever want to get me something. All right, so this is really just a stainless steel conduit, you know, that costs a lot of money. That's because the people that make it are a little bit unreasonable in their pricing. But that being said, you know, this is healthcare, and healthcare costs a lot of money. I will be looking for other ways to produce these tools in the future as these wear out. Shot? Of course, everything has to be FDA approved, and it always will be here. We don't use anything that is not FDA approved. That's the law. We have to use, everything we use has to be FDA approved. FDA just refers to the Food and Drug Administration. It's a arm of the government, United States government, that oversees, you know, pharmaceuticals and medical equipment, medical, you know, implants, things like that, tools we use in surgery. Shot? All right. Shot? Great. We're just about done, folks. Probably another 10 minutes and we'll be done. This patient had 3 herniated degenerated discs, all fixed, with one tiny little cut on her back, 7 millimeters. And I'm going to show you that little cut. We just put the same tube through that cut every time, but we just angled it through the body at different angles to get to the target. The target is always the same. It's the tear in the back of the disc where the herniation is. And that tear is what I clean up with this surgery. I clean the tear up. And there's no other surgery in the world that does that. That's because the other surgeons haven't figured out yet what I've been broadcasting for 5 years, which is that you can cure back pain and neck pain from a herniated disc if you clean the tear out with a laser. And that procedure is called the Deuk Laser Disc Repair. And I've been trying to share this with everyone for years. It just amazes me that I don't have doctors banging on my door wanting to learn this technique and use it. It just shows you how, honestly, how back-assed our medical profession is these days. I don't know what these people are thinking. It doesn't mean nobody wants to learn. Of course there are people that want to learn, but I mean, if you told me as a resident in neurosurgery that there's a way to cure back pain surgically, cure it, and neck pain, I would have been the first person in line to learn. When I found out endoscopic surgery existed, which by the way wasn't taught to me at my training at UF in Gainesville, because we weren't doing it yet. It was being done outside of academia. It was being done in private practice. It was being done in Korea. It was being done also some places in China. China, Korea, and then of course Phoenix, Arizona, which is as far away from Florida as it can be. When I found out about this minimally invasive technology, I went to learn it. I went to learn about it. I didn't know if it worked. I didn't know if it was safe, but I went to learn about it so I can make up my own mind and see if I could use it to help my patients. And as I've told the story before, I was shocked at the results when I started doing this surgery. I never thought the patients would do that well. I never thought that you could actually cure pain by doing this surgery when I started doing this procedure. The surgeons that taught me this surgery were doing it, they were doing their own version. They were doing it to unpinch the nerves. They were doing it to treat leg pain. You know, leg pain and weakness in the leg. We call that radiculopathy. But what I found is that you could actually cure back pain with the same surgery, modified from what they were doing. They were just focused on the herniation. I was focused on the tear. I realized the tear was the key. It wasn't the herniation, it was the tear. That's the brilliance of it, that nobody else figured out. That's what makes this surgery so different than everyone else's, is our focus here is on the tear. It's the tear, not the herniation, that's the source of the pain. So close they were, and yet so far away. Because the treatment of a tear is very different than the treatment of a herniation, as you can see. And of course, many people made fun of us for using a laser. They still do. Believe it or not, they still do. And now, of course, lasers are used so often in neurosurgery, spine surgery, all types of surgery. Lasers are being used more and more. But my God, they used to, and they still do, joke, laugh. But that's not the biggest problem. The biggest problem is that, as I said before, the companies that manufacture the screws and rods don't want this technology getting out. They don't want other surgeons using it. Because how many screws have you seen me put in during the surgery? 0. How many cages? 0. How much titanium? 0. How much stem cells? 0. There is nothing to put in. It's natural. All natural. And if there's nothing to put in, then the big companies don't like it, because that's where they make their money, by sticking something in your body that you don't need. You see? That's one of the biggest reasons why nobody knows about this surgery. It's because it's being kept secret by the people that control the market, the people that advertise, the big companies that advertise. They don't want you to know about this surgery, because all their profits will go away the moment people stop putting screws and rods in their bodies. I've been saying this for years. And someday the right person is going to hear this message. Somebody that can make a difference. There. See that inflammation there? That's where the pain comes from. That massive tissue at the top of the tear. I get rid of this and the back pain goes away. See, I'm sharing all my secrets. Why? Simple. Unlike those greedy oil executives, owners, insurance companies that can't see beyond their own existence, understand that life is a continuum of time over millions of years, and that their contribution is going to be so bad. I, on the other hand, understand that my life will end in a few years, and that after I'm gone, this technology has to live on. It has to be picked up because it's too important not to. It cannot die with me. And I believe someday somebody will come along who appreciates it and understands it, and we can get it out there for more people to get it done. And I won't benefit from it because I'll be long gone, and that's okay. That's the real difference between the greedy pigs that run the oil companies and the insurance companies. They don't understand they have enough. They need to share and they need to give back to the community and the world. But they're not willing to do that for some reason. I don't know why. Maybe it's the way they were brought up.
We have a question.
Of course.
One of our viewers is wondering, after this surgery, is there anything the patient can do to help regenerate the tear in the annulus more efficiently?
Yes, so the great question. They're saying, somebody is asking me, Dr. Deuk, once you're done repairing this tear, it needs to heal, right? Yes, it does. It has to heal, and it has to heal properly. And it will go through a normal healing process, which is inflammation, followed by the deposition of scar tissue, basically, collagen, elastin. And they're saying, what can I do to help this tear heal better? So, number one, good nutrition. So a well-balanced meal, protein, some carbs. Keep your sugars under control. Keep your sugars in the normal range. Your blood sugar, of course, is what I'm talking about. And vitamins, minerals, so maybe a daily vitamin, while you're healing for about a month to help your body heal the tear properly. So good nutrition, exercise, and avoid re-injuring the disc. And of course, I give you restrictions. Those restrictions are simple. Do not lift over 25 pounds for the first 6 weeks. Do not bend over and pick anything up from the ground. We have less than 5 minutes. We'll be done. So as long as you heed those lifting restrictions and the bending over at the waist you cannot do for 6 weeks, no bending at the waist. As long as you have good nutrition. The only other thing I would say, of course, is a bit cliche, but don't smoke, avoid nicotine. Right? Now, if you do smoke, you'll probably do fine, but you're asking the question, I'm giving the answer. If you can avoid the use of nicotine or tobacco products during your healing phase for about 2 months, that would be ideal. So don't re-injure it with heavy lifting or bending at the waist. Get good nutrition. Avoid things like tobacco or nicotine that are going to reduce the amount of blood flow to the tissue as it heals. And wear your back brace. We give you a TLSO, thoracolumbar spine orthosis. It's a special type of brace that prevents bending forward, among other movements. And the last thing is do your exercising. Get your blood flow, get your circulation going, right? So aerobic, low impact, yoga is okay, gradual. And that's about it. Standby laser. Just trying to grab a little bit of herniation out right there. Just about done. Laser. All right, what other questions does our audience have?
We have another viewer wondering, how long will a patient be in recovery?
This patient will be in recovery for 30 minutes. Then they'll go home. They cannot drive themselves today because they've had anesthesia. They'll need a driver. But they'll be in recovery for 30 minutes. Can you imagine having 3 bad discs you've had for 4 years causing daily pain, horrible pain? The only other way to fix them would be a fusion, except for this surgery you're watching right now, the Deuk Laser Disc Repair. She's going to go home in 30 minutes after she gets out of this operating room. 30 minutes. Maximum 45. And hopefully we can interview her on our way out of here, if she lets us, and we can ask her how she's doing. So, that said, would you please brew me a pot of coffee? I'm coming out in about 2 minutes. I'll answer any other questions our audience has. Type your questions up for me. This is the last of the tear, last of the herniation right here. Just about done. I'm very happy with the way the surgery went. And we're going to go ahead and I'm going to show you this wound. I'm going to show you how tiny it is and why the recovery is so fast. It's so fast because if you see the incision, you'll be amazed. All right. Laser off. Scope off. All right, take that and give it to me. We are done. All right, so go ahead and take a look here. Take that. Oh, here, take the fluid adapter. Yes, nice job. Great work, everybody. You got that? Okay. No post-ops. Only on instrumented cases.
We're done, Miss Carson. Be still, man.
No names. All right. Just relax. Everything's done. You're all done. You did great. So go ahead and take a look, Sean. Show our audience this tiny little cut. Y'all see that?
Yes, we do.
All right. 7 millimeters. Fix 3 discs. Go ahead and apply pressure, Sam or Luis, for 2 minutes more. I'm going to come answer questions. We lost about, I want to say 8 mils of blood, 8 mils. So that was one of the bloodier cases we've had. Normally we lose about 2 or 3. We lost 8. 8 mils, folks, is less than a syringe of blood. When you go get your blood drawn, that's like 1 test tube. It's nothing.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to DeukSpine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
Dr. Deuk did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him.
All right, everyone, thank you for joining us for the post-op Q&A. We have Dr. Deuk in the room with us now, ready to answer some of your questions. Our first question comes from a viewer on Facebook named Rosa. She asks, does stem cell therapy help with herniated disc pain?
Hi, Rosa. Dr. Deukmedjian here. Thanks, Sean. Does stem cell therapy help with disc pain? Great question. Well, I'll be honest with you. The jury's out on that one. We don't know yet. Some doctors that have injected stem cells into herniated discs have had limited success. But I will caution you. Here's why. The way stem cells work is they are pro-inflammatory. In other words, pro means for. Pro-inflammatory means for inflammation. Stem cells basically cause more inflammation. And that's temporary, of course, but it can last for several weeks or longer. Remember, the problem with the disc pain is that there's a tear, and that tear in the back of the disc is painful from inflammation in the tear. So it's actually inflammation that's causing the problem in the first place, and you go sticking stem cells in the disc, it just makes more inflammation. So we don't do a lot of stem cell injections in discs here because, number one, it's very expensive. Number two, it's really unproven. Number three, we know inflammation is the problem, and that's why people come and have their disc herniations fixed. So if inflammation's the problem, why would you want to add more inflammation? That being said, in all fairness to the treatment, I don't think it's a bad treatment. I just don't think it works as well as the Deuk Laser Disc Repair from the, we call it anecdotal evidence, which is basically, just hearsay, basically. I don't know if you understand what I'm saying. There's no proven results. It's just every once in a while you hear somebody saying, yeah, I did it on a patient and they did better. Well, there's a lot of failures too that they don't talk about. So I would say right now the jury's out, and would I do it for myself? The answer is, if I had no other choice but a fusion, I would try it. Yep. But if I had the Deuk Laser Disc Repair and I had somebody who could do that on me, I would do the Deuk Laser Disc Repair. The Deuk Laser Disc Repair is about the same price as stem cells, so why not have the Deuk Laser Disc Repair done instead? That's a proven treatment that works. And you're not sticking some stem cells in your disc. You're just getting your tear repaired with a laser. It's the most natural surgery in the world. So I would say I would definitely do the Deuk Laser Disc Repair over stem cells. They're about the same price. And the Deuk Laser Disc Repair I've been doing 14 years with 0 complications. That was our only question so far, folks. We have another one. Sean has got another one. Here, I'll give you Sean. He'll ask the question.
We have a viewer on Periscope asking, would my uncle who has a herniated disc be eligible for this surgery even though he is 93 years old?
Oh, wonderful question. So one of our viewers on Periscope is asking, would my uncle who's 93 years old with a herniated disc, and I assume he's in a lot of pain, would he be a candidate for this type of surgery? The answer is 100% yes. I told you before, we do not discriminate based on age, sex, anything, race. We take care of any human being that wants help. And a 93-year-old is suffering and they have a fixable problem that would take me 30 minutes to fix. Absolutely great idea. Would I do a big fusion surgery on a 93-year-old for a herniated disc? Probably have to think about that one a little bit. As long as they're really healthy, I think it's reasonable. But the laser surgery is a tiny cut, and it's very easy to fix that herniation and get the patient out of pain. So the answer is a resounding yes. We've operated on 93-year-olds. We've done 94-year-olds. I think I've even done a 95-year-old. Age is not a consideration when it comes to getting a person out of pain. We don't tell people ever, you're too old, or you don't have long enough to live, so what's the benefit of doing the surgery? You know, if a person comes to me and they're suffering with pain and they want to get their back fixed, I'll fix it for them. And I'll do it safely and effectively. The thing about it is, if you're 93 years old and you've got what? Let's just say you've got 2 years to live, right? I don't know how much longer you got to live, but let's say it's 2 years. You're going to be suffering every single day of those 2 years. Or you could have surgery that takes 30 minutes to do to an hour, and you will have 1 day of your life that you put risk into your life by having a surgery. And think about all those days of being out of pain that you can enjoy the rest of your life. It's worth it. It's absolutely worth it in my mind as a surgeon. I would never turn a patient away for their age. Now, if somebody was on death's doorstep and they had heart attacks and they're, you know, laying in bed every day because they can't get out of bed and they're very sick and they're on the verge of dying in the next couple of days, would I do the surgery? No, of course not, because I don't think there's a benefit to it. Now, if they really wanted it and told me I only have a week to live and I want to be out of pain, absolutely I'd do it. I'd do it, you know, because I think it's the right thing to do, is to respect what somebody wants to do for their body. It's their body, it's their choice. It's not mine, it's nobody else's. It's their choice. So I respect that. That's very important. I think all doctors should respect that. All right, that was our last question, and that was our last surgery for today. Today is Tuesday. We have more surgeries on Thursday. I think right now, Sean, what do we have?
We have 2 DLDRs. We're going to have 2 DLDRs this Thursday. That's 2 of the surgery that you just watched, and there may be more to come.
Okay, great. So if you enjoy the broadcast, and it will still be free on Thursday, and we'll be piping these surgeries out around the world for anyone to watch. Anyone can ask questions. You don't have to be someone having surgery or had surgery. Anyone can ask questions, anything to do with the spine or coral reefs or racing cars or go-karts. Bring your questions with you. I'm happy to answer them. We answer everything live during surgery. We broadcast the surgeries live from Duke Spine Institute, every surgery, every week. And the reason we do that is we want full transparency. I don't believe in dishonesty. I don't believe in lying to people. I believe in showing people what the truth is. And that's what this program is all about. It's about being truthful to the world, truthful about what we do, how we do it, why we do it. So we think this is a great educational opportunity. It's been provided by the Duke Spine Foundation for Research and Education. The Duke Spine Foundation is a 501c3 nonprofit. We do accept donations. That's the only way we make things work around here for the foundation. So if you're inclined to donate, you'll find us on the federal 501c3 legitimate foundations. And you can even find us on Apple if you like Apple phones. We're one of the foundations there, Duke Spine Foundations, DEUK Spine Foundation. Please donate to keep us going and broadcasting. And I've got some really exciting news. I met with Sonny today, the network administrator. He has the idea that we should start broadcasting these surgeries in virtual reality. That's 360-degree, 3 dimensions. For those of you who have an Oculus headset or a Vive headset or one of the other platforms, there's 4 of them now, and this is going to be the future. You put that headset on, that VR headset on, and you're going to be able to look around the operating room in 3D, and you're going to be able to see everything in HD 3D. It's incredible. This technology is coming, folks. It's already there in the video gaming world, and we want to bring it to you in surgery, spine surgery in particular. You'll be able to look all around the operating room and see what's going on. So that's probably that's a foundation project, so please donate so we can get the equipment going. And I expect that will be on the horizon and launched probably in the next 2 months. So probably around 2 months from now. Exciting stuff. If you like apps, like most people do, and you've got either an Android or an iPhone, download the Duke Spine Institute app. Go through it. It's really informative. I think it's probably the best spine app in the world right now available, and best of all, it's free. Costs you nothing. Deuk Spine Institute also offers free MRI reviews. If you've had an MRI of your neck or back or thoracic region, you're having problems, or you know somebody who is, upload their MRI. I look at it personally. I review those MRIs. We do it for free. There's no charge and there's no obligation. You don't have to treat with us. Just get your MRI reviewed. We'll give you our opinion. Take it or leave it. Do what you want with it. Throw it in the garbage or use it to get fixed. It's up to you. But you're getting the opinion of a 22-year expert in spine surgery, neurosurgeon, and you get it for free. Okay? Thanks again for joining us. And we'll be back Thursday morning with a broadcast of more live spine surgery from Deuk Spine Institute. Thanks, Sean, for putting together this great program. We'll be doing MRI reviews with MRIs, the reports at the beginning of the surgery, so you can kind of see what's going on with the patient's back or neck and why they're having their surgery. If you have any other questions, get them out real quick. I'll answer them for you. If not, have a wonderful evening, and we'll